Hey everyone, welcome back. Today we're diving into a really fascinating endocrine topic that nurses see often: Cushing's syndrome. It's one of those conditions that, once you understand what's happening inside the body, all the signs and symptoms just start to make perfect sense. So grab your notes, relax, and let's walk through this step by step, like we're chatting in class or during a clinical huddle. But before we begin, check out our extensive nurse test bank to help you pass nursing school and the NCLEX. Link is in the description below. So, what is Cushing's syndrome? In simple terms, it's a hormonal disorder caused by prolonged exposure to high levels of cortisol, the body's primary stress hormone. Normally, cortisol helps us handle stress, regulate blood sugar, and maintain blood pressure. But when there's too much of it for too long, everything goes a bit haywire. You can think of cortisol like coffee. 1 cup helps you feel alert and focused, but 10 cups every day? Not so great. Now, where does all this extra cortisol come from? There are 2 main pathways. Sometimes the body itself produces too much. We call that endogenous Cushing's syndrome. Other times, it's caused by taking high doses of corticosteroid medications, like prednisone, for a long period, and that's known as exogenous Cushing's. In fact, the medication-induced version is the most common cause overall. When it's the body's own doing, there are a few possibilities. One is a pituitary tumor that releases excess adrenocorticotropic hormone, ACTH, stimulating the adrenal glands to pump out cortisol. That's specifically called Cushing's disease. Another is an adrenal tumor itself making too much cortisol. And then, there are ectopic ACTH-secreting tumors, like certain lung cancers, which trick the system into overproducing cortisol. Now, let's talk about who's at risk, and, what contributes to it. Patients taking long-term steroid therapy for chronic conditions, like asthma, rheumatoid arthritis, lupus, or transplant immunosuppression, are at high risk. Endogenously, women are affected more than men, especially between the ages of 20 and 50. And if a person has uncontrolled stress, obesity, or certain tumors, those can also play a role. So how would our patient with Cushing's syndrome look or feel? Oh, you'll start to recognize this picture right away. One of the most classic findings is a round moon-shaped face. Then, there's the buffalo hump. That's a fatty pad on the upper back or neck. The body fat distribution changes dramatically. Fat accumulates in the trunk while the arms and legs become thin due to muscle wasting. The skin becomes fragile and thin, leading to purple striae, those purplish stretch marks, especially on the abdomen, thighs, or breasts. They may bruise easily, and wounds take longer to heal. Because cortisol affects glucose metabolism, these patients often develop hyperglycemia, sometimes even steroid-induced diabetes. You'll see hypertension because cortisol enhances sodium and water retention. Many people experience osteoporosis, muscle weakness, and just plain fatigue. Women might notice things like menstrual irregularities, hirsutism, that's increased facial or body hair, and even acne. For men, decreased libido and erectile dysfunction can occur too. And don't forget the emotional side. Irritability, depression, or even mood swings are pretty common because cortisol influences mental health too. It's one of those conditions where the patient might say, "I just don't look like myself anymore." As nurses, that's something we really listen for. Physical changes are important, but emotional distress is just as significant. So how do we confirm that what we're seeing is really Cushing's syndrome? That's where diagnostic procedures come in. First, providers look at lab tests to measure cortisol levels. A classic test is the 24-hour urine collection for free cortisol. If it's elevated, that's a big clue. There's also the low-dose dexamethasone suppression test. Normally, giving dexamethasone should suppress cortisol production, but in Cushing's, the levels stay high. Providers might also check serum ACTH levels to determine whether the problem is pituitary or adrenal in origin. Imaging studies, like MRI of the pituitary or CT scan of the adrenals, help pinpoint any tumors. Sometimes late-night salivary cortisol tests are used too, since cortisol normally drops at night, but in Cushing's it doesn't. Now that we've identified the problem, what's our role as nurses? Nursing actions are all about supporting the patient, monitoring for complications, and preparing them for treatment. First, we monitor vital signs, especially blood pressure and blood glucose. Both tend to be elevated. We also assess for fluid overload, noting things like edema or rapid weight gain. Because of their weakened immune system, these patients are high risk for infection, so hand hygiene, avoiding crowds, and monitoring temperature are crucial. The skin is delicate, so use gentle handling and mild soaps, and encourage repositioning to prevent skin breakdown. Emotional support is huge. Imagine suddenly gaining weight, growing facial hair, or developing a hump on your back. It's not just physical, it's emotional. Let them express those feelings without judgment. If the cause is medication-induced, the nurse collaborates with the healthcare provider to gradually taper steroids, never stopping them abruptly, since that could cause adrenal crisis. If surgery is planned, like an adrenalectomy or pituitary tumor removal, prepare the patient preoperatively and monitor closely afterward for adrenal insufficiency. After surgery, they might need temporary or lifelong glucocorticoid replacement therapy, depending on how much adrenal tissue remains. Treatment really depends on the cause. If it's from long-term steroid use, tapering the dose or switching to alternate-day therapy can help. If it's due to a pituitary tumor, transphenytoid hypophysectomy may be done. For adrenal tumors, adrenalectomy is the approach. Sometimes radiation or medications like ketoconazole or mitotane are used to suppress cortisol production if surgery isn't an option. After treatment, cortisol levels must be monitored regularly to make sure they normalize and don't swing too low. Now, patient education. This is where your nursing communication skills shine. Teach patients the importance of medication adherence, especially if they're on steroid tapering schedules. Explain the signs of adrenal insufficiency, like weakness, dizziness, or hypotension, so they can report them right away. Encourage a balanced diet, high in protein, calcium, and potassium, but low in sodium and sugar, to combat muscle wasting, bone loss, and fluid retention. Weight management and regular activity are encouraged, but nothing too strenuous until they're stable. Because the immune system is compromised, stress hand hygiene, avoiding sick contacts, and monitoring for fever or any infection signs. Emotional health is just as vital. Reassure them that with proper management, most of the physical changes can improve or even reverse over time. And if they're on long-term steroid therapy, just remind them to wear a medical alert bracelet stating they're on corticosteroids in case of emergencies. By the time you meet a patient with Cushing's syndrome in the hospital, you'll be able to pick up on those classic clues, like moon face, truncal obesity, purple striae, and high blood pressure, and you'll know exactly what to assess and how to care for them. Remember, as nurses, you are the first line in recognizing patterns, preventing complications, and empowering patients to understand their condition. And that's it. You did it. You've just covered Cushing's syndrome from definition all the way to patient teaching. Remember, too much cortisol means too much stress on the body. Recognize the signs early, monitor closely, and support your patients through both the physical and emotional parts of recovery. Thanks for learning with me today. Keep going, keep studying, and I'll see you in the next nursing review session.